Hello, this is John Hunley. I'm the surgical director for liver transplantation at Piedmont, Atlanta. And today we're going to be talking about how to get a liver transplant. So the title of this talk is From Listing to Transplantation. Before I get into that, I always like to start with a slide that kind of reminds us of what we're doing here at Piedmont. And for you, the patients, I want you to see this. So our core mission statement for our Transplant Institute, we call it True North, is to make a positive difference in every life we touch. By leading a top 10 transplant program, Piedmont Transplant Institute pursues clinical excellence in every patient encounter in an environment that honors and supports the team. So we have 4 pillars, we call them, for that kind of support that core mission. And we think about these 4 things every day. I think about them when I'm accepting livers for you, for the patients. And the 4 things that we really want to focus on in our liver transplant program are decreasing waitlist mortality. So obviously we want our patients to live. We want them to survive. We also want to decrease suffering for patients on the waiting list. And that means that for patients that aren't necessarily at risk of dying, but are suffering a lot, we also want to get them transplanted. And basically we want you to have a long, healthy life with a good quality of life. We want to have great post-transplant outcomes. And we also think about the donor's gift. So we want to honor the donor and the donor family's gift. We want to take good stewardship of that gift and use it wisely. So those are the 4 pillars of our program. Today, we're going to talk about from listing to transplantation. And I'm just going to go through this overall summary real quickly, and then we'll get into each of these in a lot more detail later. So the first part is just, I'm now listed. How do I get transplanted? And we're going to talk about how the whole listing and transplant process works, who gets offered what organs, and how does that work? The next thing that we're going to focus in on is what kind of liver offers will you as patients be offered? We'll talk about donation after brain death, donation after cardiac death. We're going to discuss patient risk factors, so donors that have risk factors for bloodborne diseases. We'll also talk about infected livers, so donors that have hepatitis C or hepatitis B, and what that means for you. The third part of our talk will be discussing new technologies that exist that help your liver do well after transplant. We're going to talk about normothermic regional perfusion, Paragonix liver guard, normothermic machine perfusion, and then hypothermic oxygenated perfusion. So all those technologies, you don't have to understand all the details of how they work, but we feel like it's important for you to understand what we're doing to make sure that your liver works well after transplantation. And then the last part of the talk is we're going to talk about how does our group of surgeons and group of transplant hepatologists, how do we decide what liver is the right one for you? And that'll be the way we wrap the talk up today. So first part is, I'm now listed. How do I get transplanted? The first thing is who benefits from liver transplantation. And we're going to talk about that on subsequent slides. But basically, patients with high MELD scores, so people that are really sick, benefit from a survival standpoint. So if your MELD score is really high, then you are very likely to die. And obviously, you have a clear benefit with liver transplantation. Patients that have cancer, so primarily liver cancer called hepatocellular cancer, are patients that benefit from liver transplantation as well. There are also a couple of other less common transplants or less common diagnoses for cancer, metastatic colorectal cancer and cholangiocarcinoma, and those patients also benefit from transplantation. And then the second cohort of patients that we feel like benefit from liver transplantation are people that have miserable quality of life. So if your quality of life is really poor, but you're unlikely to die, we still feel like those patients benefit tremendously from liver transplantation. So UNOS is an organization that is national. It's a government organization that allocates livers. So they decide what liver goes to which patient and in what order. And the primary tool used for that system is the MELD score. And we're going to talk a lot about that in a minute. And I'll also explain to you what MELD exceptions points mean. But essentially, the MELD score uses labs to assign a number that predicts what your risk of death is without a liver transplant. Patients that don't have high MELD scores but do have high risk of death, the best example being cancer patients, but there are some other diagnoses as well, they are given exception points. So their actual MELD score might be 10, but if they have cancer, they might be given a score of 27 or 28 points to get them higher on the list so that they have a shot at getting a transplant. So when do you need a liver transplant? It's essentially when the risk of death without transplantation is greater than the risk of death with transplantation. So transplantation, liver transplantation, is a really big operation with a lot of potential complications associated with it. The biggest of those complications is the risk of death. And what we want to do with our patients is determine when is their risk of death without transplant greater than the risk of death with transplant. The first step in figuring that out is what are the risks of liver transplantation. So in this country, about 1% of patients die during the liver operation itself, during the transplant. That percentage is a lot lower at Piedmont, but nationally it's 1%. And 3% of patients never make it home after a liver transplant. So that's a pretty big number. And that's, again, a statistic for this country. At Piedmont, our statistic is a lot better than that. Beyond just the operation itself and recovery from the operation, there are a lot of long-term risks of liver transplantation, most of which are related to the fact that you're going to be on immunosuppression, which will increase your risk of infections. You also have some side effects from the medications that we put you on, which can affect your long-term survival. The main one being kidney failure. So one of the medicines that we use to prevent you from rejecting the liver can over time hurt your kidneys and can lead you to require dialysis or need a kidney transplant. And then recurrence of liver disease is certainly possible, specifically in patients with HCC, which is liver cancer, primary sclerosing cholangitis, or autoimmune hepatitis. Those patients have some risk of recurrence of liver disease. And that's something to keep in mind when you consider the risks with liver transplantation. And then for every single cancer out there, the risk of getting that cancer is higher with immunosuppression. So after a liver transplant, while you're on immunosuppression, the relative risk of getting cancer is higher across the board. It's not a huge number. So I'll give you an example. Right now, if you look on this screen and you see colorectal cancer, the relative risk of getting colorectal cancer is twice as high with a transplant compared to a patient without it. So if your current risk of getting a colorectal cancer is 1 out of 500, based on your family history and all that kind of stuff, then it would be 2 out of 500. So it's not a huge increase for most of these cancers, but some of them are more significant. So non-melanoma skin cancer, which isn't a huge threat to your life, but it's certainly it can lead to a lot of medical treatment. The relative risk for those kinds of cancers increases by 30 times after you get a transplant. And that's all related. The risk of cancer is related to the fact that your immune system is the first barrier to you getting cancer. So when a cancer cell first develops, your immune system is responsible to identify it and kill it. And if your immune system can't do that effectively, then you're more likely to get cancer. So the risk of cancer is not huge, but it's certainly higher with liver transplant. All right, so these are the general risks of liver transplantation. And now we'll look at what are the risks for patients that don't get a liver transplant but have liver disease. So the MELD score stands for the Model for End-Stage Liver Disease, and it uses 6 different factors to kind of come up with a number that ranges from 6 to 40, and that tells you what your risk of dying is without a liver transplant. So those 6 things are INR, which tells us how your liver is making proteins to clot the blood, creatinine, which is a measurement of your kidney function, total bilirubin, which is a measurement of your liver's ability to digest and metabolize different toxins, bilirubin being the most important one, sodium, albumin, and then what your gender is, so male or female. And that range goes from 6 to 40. So what does that mean? So a MELD score of 6 means that you have about a 3% chance of mortality without a liver transplant. And so relatively low. It might even be a little lower than that, but relatively low. If you look at patients all the way to a MELD of 40, so a typical patient with a MELD score of 40 is in the ICU. They're often on dialysis machines because their kidneys have failed, and they are dying and dying very quickly. And their risk of mortality without a liver transplant is more than 99%. So they're at very high risk of death. So as you can just think, a typical patient with a MELD score of 6, we wouldn't transplant. A typical patient with a MELD score of 40, we would definitely transplant unless there's some reason that we can't do that, because they are very likely to die. And the question is, at what MELD score do you have a benefit of transplantation? So back in 2005, if we go about 20 years, you'll see that the survival after transplant was around 85, 86% for most patients after a liver transplant at a year. And so we decided that a MELD score of 15 was kind of the cutoff. So if you can see, your 1 more year mortality without a liver transplant was about 14%. It was about the same with a liver transplant. And so we would say, below a MELD score of 15, we really shouldn't transplant you. Getting up above 15, that's when there's a clear survival advantage. Even at a MELD score of 24 back then, you were much, much more likely to die without a transplant than with one. Now, as we progressed over the last 20 years, our outcomes have gotten better and better with transplantation. And so in this country in 2023, our risk of mortality, risk of dying dropped significantly down to around 6% overall for patients. And so if you look at our data that came out in January of 2025, the 1-year patient mortality in this country after a liver transplant was about 6%. At Piedmont, it was about 3.7%. And so really the number at which you benefit from a transplant has dropped significantly over time as we've gotten better and better at performing liver transplants. So for most of us would say somewhere in the range of 10 is where the MELD score, there's a clear-cut advantage with liver transplantation. And that really depends a lot on what your personal problems are, what your signs and symptoms of liver disease are. This is just a slide that kind of points out the fact that the higher your MELD score is at time of transplant, the worse your long-term outcomes. So it's not hugely different, but it's enough that we know that the best outcome for a patient is to get transplanted before they get really, really sick and are in the ICU. You can imagine that if you're at home with a MELD score of 20 and you're still walking, you're still able to take care of yourself, you do a lot better with the transplant than you do if you've been in the ICU for a few weeks and your liver is completely shut down and you're dying. So this slide just shows that there is a clear benefit to getting a transplant early. So the question is, do we ever transplant patients with low MELD scores? And the answer is yes, we do. So the primary reason that we do that is for cancers like we talked about before, and I listed those different cancers that are most common. So those cancer patients receive a MELD exception score. Many of them, their laboratory MELD score is only 6 or 7, but they'll get up to a 27 or so, depending on what their diagnosis is. And then there's a second cohort of patients that have extremely poor quality of life, and we are able to transplant them as well. And we're going to go through what kind of liver we can get for someone like that. But a good example of a patient like that would be someone with a MELD score that's 10 to 15. They're very low on the list, so they are unlikely to get a great offer for a liver. But we know that they can't live long the way that they are. So these are patients that have really poor control of their hepatic encephalopathy. So Those are patients that are very confused. Many of them are in and out of the hospital over and over again. I met somebody recently who had been hospitalized for 70% of the year for the prior year because they couldn't get control of their encephalopathy, their confusion. And patients like that with low MELD scores, we still can transplant with marginal livers. And that's what a lot of this talk is going to be about today. So UNOS, I told you that UNOS is a national organization that allocates organs from deceased donors to patients who are on UNOS's active waiting lists. So livers are allocated to patients essentially according to two criteria. The first being the MELD score, which includes patients with exception scores. So if your MELD score is 40, you will be above the person that has a MELD score of 39 and on down to the patient with a MELD score of 6. And then the other thing that factors in is how close the donor and recipient transplant center are to each other. And the allocation system has changed over time, but basically these are the two criteria that are important in the allocation system. A liver is then offered to the first patient on the list. So typically that'll be somebody that is a status 1A patient or somebody that is in what we call acute fulminant liver failure. There's somebody that is dying very quickly, expected to die within the next few days. So if there's someone like that on the list, they will get the liver that's offered first, and then it then goes to the next patient on the list. So if the liver isn't perfect, if it isn't a young, thin, perfect labs, everything's perfect, then a lot of times the first patient's team will believe that they will survive to get a better liver offer. And so the team will pass on this liver, and then it will go to the person who's second on the list. They might also pass because of other reasons. So for instance, if the liver is too big or too small, or if there's specific things anatomically that don't work for that first patient, then the next patient on the list will get offered. And this continues until the liver is accepted or until the entire nation has turned the liver down. So there are many livers that are transplanted to people that are hundreds down on the list, but that's because they're very marginal livers that would only be acceptable for certain kinds of patients with certain kinds of technologies. And so that's how we sometimes transplant people who are way down on the list. So what kind of livers will I be offered once I'm on the list? We're going to talk about donation after brain death, donation after cardiac death, some risk factors that you need to understand, and then, the use of infected livers, people that have hepatitis C and hepatitis B specifically. So first, donation after brain death. Donation after brain death livers account for about 75% of deceased donor liver transplants. The donor in these patients is typically someone with a head injury of some sort, either a stroke or a trauma patient, and they're declared deceased due to brain death, and the donor and or the family have agreed to donate their organs for transplant. So many of these donors are people that have taken the time to go online and sign up to be organ donors. This is beyond what is normally done in the driver's license process. These are people that actually get online and sign legal consent for donation. When donors haven't done that, then the family or loved ones are the ones that agree to donate organs for transplantation. The heart is still doing its job in these patients. So the patients are brain dead, but their organs are still working. They're on ventilators to keep them breathing. But generally, the liver is really happy in this situation. The heart's working. They're still getting fed. Everything's normal to that liver. And so these livers do really well after transplantation. Donation after cardiac death, or DCD livers, account for roughly 25% of deceased donor liver transplants, although I will say that that number is going up and up and up. As we've used new technologies for these livers, it is becoming more and more common. The patient in this case is not deceased, so the donor is not dead yet, but the family knows that that patient is unlikely to survive. The family and the ICU team have decided to withdraw care on the patient, and then the family decides that they want to donate the organs if possible, and that's what a DCD is. So in this situation, the patient is transported to the operating room and the ICU team withdraws care in the same fashion that they would have in the ICU. If the patient dies quickly, the transplant team is then able to recover their organs. And this begins after a prescribed period of time. It's usually about 5 minutes. The heart has to be stopped for at least 5 minutes before the transplant team can start the recovery process. Because we have to wait for the patient to die and then wait again for a while after they die, DCD organs historically and livers specifically did not do as well as brain dead livers. And we're going to talk a lot more about this later, but essentially the process of dying, the livers really had some injury to them that made us very hesitant to use these organs. One of the things that you'll hear about when you're on the list, and if you get an offer, very commonly, it's probably around 25% of our patients, the donors have PHS risk factors for bloodborne diseases. And the three that we're talking about when we discuss bloodborne diseases are HIV, hepatitis C, and hepatitis B. So all donors are tested for both antibodies and nucleic acids, so the actual virus for each of these three diseases. And we will have all of these studies back before you're transplanted. And so we'll be able to tell you that they tested negative for these antibodies, they tested negative for these viruses, or we'll tell you that they were positive. These labs aren't perfect. So if a donor was recently infected, these tests could be falsely negative. So every time that we do a transplant, you are at risk for transmission of infections or transmission of cancers. Those are the two things that can be transmitted through transplantation. The risk factors for bloodborne diseases are pretty understandable. So sex with a person known or suspected to have HIV, hepatitis B, or hepatitis C infections, men who have had sex with other men, sex in exchange for money or drugs, drug injection for non-medical reasons, incarceration, and then children who are breastfed by mothers with HIV infections. And the last reason would be someone that we just don't know their medical history. So a family that's been alienated from the donor might not know all of the medical history. And so we'll label that person as a PHS increased risk for these bloodborne diseases. And when you get a call that you're being offered a liver from a donor like this, we'll let you know why they're at risk. We'll let you know what the lab showed. And we want you to know that we carefully consider the risks before we make this offer to you. So all three of these infections can be treated and are compatible with long-term survival. So that's the first thing to understand. When we get the test that says they don't have HIV, they don't have hepatitis C, that test isn't perfect, but for the vast majority of people, the test proves to be accurate and true. But it is possible that you could get one of these infections. All three of these used to be deadly, but all three of these can be treated very well and are compatible with long-term survival. We have had patients that have refused a liver, and I personally have had several through my career that have refused a liver because they were concerned about the risk factors. And we just want to make sure that you understand that this could be your last offer. So I've had patients who have turned a liver down and then within a week or two died before they were able to be transplanted. We wouldn't offer this liver to you if we didn't think that it was the best thing for you. And generally what we ask is that if you're offered a liver with risk factors, that you strongly consider, and we really recommend that you accept that offer. Some of the best livers out there right now are patients with risk factors. As you know, there's an epidemic of drug use in this country, and a lot of young people especially are overdosing on medications, and they're therefore at increased risk for bloodborne diseases. But they are typically young with really perfect livers, and these are livers that I would use for my children if they needed a liver transplant. And we strongly recommend that you would consider these livers. So what are reasons that a transplant center might pass on a liver for one patient and then potentially take it for another patient? The most common is donor age. So donor age is something that really impacts the long-term survival of a liver transplant. That's true historically. It's less true now with new technologies that we're going to talk about. But for instance, if we had a patient who is in the ICU, their MELD score is 40, but they're relatively stable, and we think we've got, a week or 10 days to find them a liver transplant, we wouldn't use a 70-year-old liver for them. We would wait until they got a 20 or 30-year-old liver. So that's one of the more common ones. In the past, especially, donation after cardiac death would be a reason to pass for a patient and take it for a different one. So we wouldn't typically use these for patients with high MELD scores, although that is changing now with new technologies. Donor liver fat content is something that is really important. So if the liver has a lot of fat inside of it, at the time that the liver is reperfused or blood is put into the liver as we transplant it, that can release toxins into the blood that can really hurt the heart. And so we might turn that down for somebody that has a marginal heart. So if you're 65 years old and your heart's okay, but not great, we wouldn't use a super fatty liver for you, but we would definitely consider that liver for someone who is younger with a strong heart. So that's one of the things that we consider when we're discussing what organ to take for which patient. Donor liver enzymes or bilirubin are also part of the equation, and that's something that we might use a liver that's taken a little bit of injury to it for one patient and not for another, and that's a complicated decision-making process, but that's one reason. Then anatomic considerations really matter. So just size overall of the liver matters. It needs to be able to fit into you comfortably, obviously. Sometimes recipients with calcified arteries or clotted portal veins, those patients generally will require younger, healthier donor livers. And so we'll wait for a good liver for a patient with one of those problems. So this is how livers used to be allocated. This is just kind of a rough idea of what allocation used to look like before all the new technologies that we're going to discuss. A typical 20-year-old donation after brain death, so that's DBD liver, would go to the first person on the list. So if you have a great liver offer, that's going to go to the patient who is number one on the list, unless there's some reason they can't get transplanted. If it's a good liver, but not a perfect liver, so a 50-year-old brain dead liver, that would slide down to somebody at sequence number 8, who might have a MELD score of 34. So they have a high MELD score, they're at risk of dying in the next month or two, but not necessarily in the next week. And so that liver might slide down to somebody at a sequence of 8. If they were about 50 years old and very obese, the liver's not quite as good of quality, and that might slide down to somebody with a MELD score of 30 at sequence number 16. And then as you get more and more risky in terms of what the quality of the liver is, the liver would slide down further and further down the list, all the way down to a 60-year-old donation after cardiac death liver. In the past, no one used livers like that, and that liver would have been discarded. And so that's generally how allocation worked previously. Now, that has changed tremendously now with new technologies. So that's the next part of this talk, is we're going to talk about predominantly 2 technologies, but really 4 total that are really helping us with liver transplant outcomes and helping you to get transplanted. And I'll just say, I did my first liver transplant in 2004, and over the last 20 years, not a lot changed in liver transplantation until around 2023, when these new technologies emerged. And it has been a tremendously exciting time in liver transplant, because for the first time, we feel like we're on the road to getting to the place where people aren't going to be dying waiting for livers, that we actually will be able to have enough livers for patients with liver disease and be able to transplant them all. And so it's really an exciting time, and that's largely due to this technology. So it's been a huge paradigm shift in our transplant community, and we're sad that you have liver disease, but if you ever had to have it, it's good that you have liver disease now, because your chances of dying waiting for liver transplant have really decreased greatly over the last few years. donation after cardiac death. I explained to you already that DCD livers had complications associated with them before all the new technology. So historically, about 10 to 15% of livers from DCD donors that died of cardiac death, had severe injury to the biliary tree. So the biliary tree drains bile from the liver, and it's the most susceptible part of the liver to organ ischemia damage. So if you don't have enough oxygen going to your liver, the first part of the liver to die is the biliary tree. And so in patients that were donation after cardiac death donors, they would develop something called ischemic cholangiopathy, which just means disease in the bile ducts due to that lack of oxygen. And about 10 to 15% of those patients would have bad enough injury that they would wind up having to be retransplanted, or they would die because of this. And that's why at Piedmont, historically, we were very cautious with these kinds of livers. We used far less than 5% of our livers were from DCD donors. We were very, very selective with these donors. But new technology has changed that tremendously. We're currently doing almost 50% of our liver transplants are DCDs. And that's because of new technology that has made DCD livers almost as good, if not equivalent, to brain dead livers. The new technology that we use the most are these two: normothermic regional perfusion, which we call NRP, which is ECMO for DCD donors. So it's essentially a heart-lung machine that we use for DCD donors. The second technology is normothermic machine perfusion, and we call that liver pumping. So if you hear of a liver pump, that's essentially what this is referring to. And there are two companies right now in this country that have the market, Transmedics and Organox. And there are more companies that are working on similar machines, but generally these machines are very similar to each other, and we're going to discuss that. So NRP, or normothermic regional perfusion, essentially is a heart-lung machine. So in the past, when a donation after cardiac death donor died in the operating room, like we've discussed already, the ICU team would withdraw care. We would wait 5 minutes after the patient died. And then after they'd been dead for 5 minutes, we'd very, very quickly open them up, flush the blood out of their organs, cool everything down with ice, take the liver out, rush it back to the hospital, and do a transplant as fast as we could. And what we found is that the faster we did all those things, the better those livers did. Now what we do, and we do this at Piedmont 100% of the time that we accept DCD livers, maybe 99, but close to 100%, we use normothermic regional perfusion. And so what we do is, as soon as the patient dies and that 5 minutes of time expires, we open the patient up and we put them on a heart-lung machine that restores blood flow to the abdominal organs, so that within a minute, the liver is alive and happy again. And we continue giving the liver everything it needs, oxygenated blood flow, for about 90 minutes. And during that 90 minutes, we test the labs to see if the liver is functional, if it's happy. And then after that 90 minutes or so of time, we then remove the liver and bring it back for transplant. This is what that machine looks like. And it's similar to what you'd use for cardiac surgery. It's essentially a oxygenator and a pump that replace the function of a lung and a heart. The data for using NRP for DCD livers is amazing. Even if you don't pump the liver afterwards, if you just go straight to transplant after NRP, as you can see on this graph, this is percent survival for patients with NRP at the top dark line compared to patients without NRP that get DCD livers. And as you can see, the survival for these patients is excellent. At 5 years in this study, the survival was greater than 90%, which is really a phenomenal percent survival after transplant. And essentially every complication is lessened with NRP. So patients that get a transplant using NRP have improved graft and patient survival. They don't get transplanted again as often. All biliary, all bile duct complications are reduced, and that includes the dreaded ischemic biliary complications that we talked about. We also have a decrease in hepatic artery thrombosis or clotting off, which is a very serious complication after liver transplant that usually requires retransplantation. There's a reduction in post-op kidney injury as well. And so NRP is great, and it's something that we use almost every time we use a DCD liver. NMP, so normothermic machine perfusion, is what we'll talk about next. And this photo is a photo of the Organox Metra device, which is a very common pump that is currently used in the United States. And essentially, it is the same kind of thing as the NRP machine, but it's for just the liver. So it's a heart and lung machine that pumps oxygenated blood into the liver. We actually can feed the liver while it's on the machine and keep the liver happy for weeks, we think. Certainly days. Patients have been transplanted with livers that have been pumped for as long as 3 days, and there's no reason to believe that you can't just keep the liver alive kind of indefinitely. So liver pumping is amazing. It allows us to pump the liver and keep it alive right up until we put it into you. So just 40, 45 minutes before the liver is reperfused into you, it'll be alive and happy on the liver pump. And it has greatly reduced all kinds of problems that we see with marginal livers, especially. So better patient outcomes, better graft survival, lower length of stay, less time in the ICU, less kidney injury, less postoperative dialysis, less blood utilization during the transplant. The livers basically work very quickly and really do really well. Now, I'll tell you that a young, perfect liver doesn't need any of this technology to work well. Young, perfect livers work well almost all the time, no matter what. But these technologies really help with the more marginal livers. So livers from older donors or livers that have other risk factors associated with them. So there are fewer complications with livers that get pumped on the machines. And liver pumping generally turns a marginal liver into a good liver, and it turns an unusable liver into a usable liver. And this is something that's been really exciting over the last few years. It is particularly wonderful for high-risk surgical candidates or high-risk cardiac candidates. So if you've had a lot of prior surgeries, in the old days or just a few years ago, we had to wait for a perfect liver for you because many times that liver would need to stay on ice for 7, 8, 9, even 10 hours while we struggled to remove your old liver because of all the scar tissue or other complicating factors. But now we can operate on these patients and do their transplants without any real concern for how long the liver has been out of the body because it's on the pump and happy. And so it has been a wonderful thing for our patients with high-risk surgical problems. And it's also something that has really benefited people with marginal hearts. So if your heart is marginal, the pumped liver does a lot better with reperfusion of the liver. Hearts generally tolerate reperfusion much better. And so there are a lot of patients that we're able to say yes to for transplant that in the past we wouldn't have been able to do that. So that has been a huge benefit. Liver transplants performed at convenient times now. So a lot of times we'll take the liver out in the afternoon from a donor, put it on the pump and wait and do the transplant in the morning, which is just good for the team. You can understand that all things being equal, getting a transplant in the morning is better than getting one at midnight. Some other technologies that have come out recently are also utilized at Piedmont. So Paragonix LiverGuard is a cooler that is just a little better than a normal cooler. So normal coolers use ice, and what we see in those livers is that the temperature can drop down to close to 0 degrees Celsius. This device maintains the temperature between 4 and 8 degrees Celsius, and that is a little bit better for the liver. So it causes less preservation injury to the liver, and it lowers early allograft dysfunction. We see less acute kidney injury, and we see that you can safely prolong the time that the liver is in the box. So an example of when we would use this is if we have a long transport time for that liver, we'll use LiverGuard, and that is definitely helpful. So you might have a patient that receives a liver from a donor that got NRP and then gets liver guard to bring the liver back to Piedmont, and then we put it on a pump. And so 3 different technologies could be used in one patient. Another technology that is emerging is hypothermic oxygenated perfusion. So the liver pumps that we traditionally have been using use blood to perfuse the liver, but there's also benefit from this machine, which is simpler. It has good outcomes. It's a lot less logistically complex. And you might receive a liver using this technology as well, it's emerging right now. And over the course of the next few years, these different devices will continue to come out from different companies that are using these devices to improve your outcomes. So Piedmont, our DCD liver transplants have excellent outcomes thanks to these technologies that we use. All livers will undergo either NRP, liver pumping, or oftentimes both of those technologies to make sure that your outcome is good. So the last part of our talk is, how does Piedmont decide what liver is right for me? So going back to our traditional list, and this is what the list looked like for 20 years up until 2023 or so. This is how livers were allocated. And now we use a piece of information to really help us figure out who to give those livers to. So I've intentionally blurred this spreadsheet, but I just wanted you to know that we have a spreadsheet that we use that you are on, that we have internal access to, that helps us figure out in real time, even at 3 a.m, what is the best liver for this patient? Who can I use this liver for that would benefit the most? And the things that are on this spreadsheet, and we call it the WOW, the Waitlist Optimization Workbook. Every single listed patient is on it. And the main things that we have on this worksheet that help us figure out in the middle of the night who is this liver best for are your surgical risk, your cardiac risk, and then something that we call the quality of life index. And the quality of life index is something that we use. Each of your hepatologists will assign a color score to just basically how miserable are you? How often are you in and out of the hospital? Are you able to leave the home? Are you having a quality of life that is good? That score is really something that helps us make sure that we don't give marginal livers to people that have low MELD scores and decent quality of life. As your quality of life gets worse, or if the hepatologist is concerned that even though your MELD score is low, you're at great risk of dying, they will change your quality of life score. And that just helps us as a surgical team to understand how sick you are and how desperate you are. Some other things that help us in the middle of the night to figure out what liver is best for which patient is the abdominal size. So we're going to take measurements of your abdomen and make sure that we have a liver that can fit well inside of your abdomen. And then other considerations are included on the WOW as well. So have you had a tip shunt? Have you had prior operations? Do you have any kind of artery or vein issues that we need to know about? So using that technology, the technologies that we've talked about, and the WOW, this is how allocation might look like today. And these are just some examples. So basically, because of machine perfusion and NRP and all these new technologies, livers have now shifted to using them for people that are higher on the list. So a more marginal liver, like let's say a 65-year-old donation after brain death liver with a BMI of 40, so they're obese. In the past, we might use that for somebody with a MELD score of 20, but now we would pump that liver and use it for someone that's higher up, maybe at sequence number 30. And going down to the bottom of the list, so a 60-year-old DCD that in the past we would have discarded, we now can give to patients that are higher on the list, MELD scores of 15 to 20. A 60-year-old DCD liver with this new technology has become a really good liver, and those livers do really well both in the short term and the long term. And even 90-year-old brain dead livers or 70-year-old DCD livers have become livers that we can now use and transplant safely And we typically will use those for patients that have very low MELD scores, but miserable quality of life, people that are desperate for a transplant and don't really have a hope of getting a transplant because of where their MELD score is. We have successfully transplanted a lot of patients over the last few years with older livers and have really achieved great outcomes. So this is what liver allocation looks like now. So this is data from January of 2025. And I just want to go through this to give you an idea of how we're doing as a transplant program. And we'll wrap up our talk with this. The most important statistic here is this one. This is the hazard ratio for patient mortality after listing. And as you can see, this is Piedmont Transplant at the top. There are two other regional centers that I haven't named that are nearby just to compare us to them. And the most important statistic is, what is your hazard ratio for death after listing? What that means is, compared to what's expected in the country, how likely am I to die once I'm listed at this center? So that includes the time that you spend on the waiting list waiting for a transplant. Obviously, getting transplanted early helps you survive longer. And this follows the patient from then on. So just generally speaking, from the time they're listed to the time that this report came out in January of 2025, how likely is a Piedmont patient to die compared to the national expectation? So 0.75 means that at that time our patients were 25% less likely to die than expected. And then comparing that to our regional centers that are nearby, one center, it was 14% higher than expected mortality. Another center, 27% higher than expected mortality. So we're constantly striving to get better, but we do have amazing outcomes here at Piedmont. And we are very focused on long-term and short-term excellent survival after liver transplantation. A big part of that is getting you transplanted before something bad happens on the waiting list. So getting you transplanted as quickly as we can. This is a slide that just looks at every program in the country. So all these little circles are a different transplant center. And the further you get out to the right, that means that it's a bigger transplant program. And the lower you are on this list, it means that you have better outcomes. Your overall mortality after listing is lower, which is a good thing. And you can see the blue dot. There are only a couple of programs in the country out of over 120 or so that are helping more people with better outcomes than we are. And again, we're striving to be the best in the country. We're very close. So some good questions to kind of wrap up with. How long will I be on the waiting list? That really depends on all the things that we've talked about today. So what is your MELD score? What is your quality of life? How miserable are you? What is your diagnosis? It could be 2 days if you get listed with a high MELD and you're very sick. It could be a lot longer than that, depending on what your diagnosis is. And then one of the things we haven't discussed so far today is, what is your blood type? So your ABO blood type, O's, A's, AB, each of these has a different waiting list. And specifically, ABs and Bs are able to be transplanted more quickly. And O's and A's, which is what the vast majority of us are, O's and A's, have a longer time on the waiting list. So those are some factors that affect this. What MELD score do I have to get to in order to get transplanted? I hope by now, after hearing this whole talk, you understand that that is a moving target. To get a perfect liver, unfortunately, you have to be really, really, really sick, typically in the ICU dying. To get a liver that is older, that depends on all these other factors. So there really isn't a magic score. It is difficult to get a transplant with a MELD score below 15, but we are able to transplant people with lower MELD scores who are really miserable and really need transplantation. So I just want to wrap up this talk again with my first slide, which is, our goals for our transplant program are no waiting list deaths. That's what we hope to achieve in the next decade as we get more and more technology to help us transplant you more quickly. We want transplant patients to be transplanted as soon as they're listed. So that's our goal. That's what we want to achieve We want to have the best outcomes in the country, and we want to utilize every opportunity to use every single donor's gift as well as we can. So these are our goals. We're getting really close to achieving them and excited to be marching alongside you all as you go through this difficult time. Thank you so much for your attention, and that is the end of my talk. I appreciate it.